Okay, so good afternoon, good evening, everyone. Um, Starting the new year. So I've said in the past that I will be doing some lymph node teaching as well as Haempath teaching, and I'm grateful for your continued interest in Haempath. Next week, it'll be Dr. Nick Orsi talking about endometrial uh, pathology. But today, what I'm going to do is I'm going to start going through a long series of Haempath teaching that I've previously delivered in Kenya and Zambia. So some people who've been associated with this course for many years now will actually maybe recall some of the information, but of course we're trying to share it to other people. So if I share my screen to start with, and I'll give you just an outline of what we're going to do, and today will be kind of a kickoff day, a kickoff for yourselves. So please be as interactive as possible. Please put things in the chat. It'll also be a kickoff for me navigating this course that I've previously prepared, and also the Leeds virtual pathology site, which has got a huge amount of information. So if I just start off with this, maybe if someone could confirm that you can see this share now. Yep. Anyway, yep, great. Thanks, Sarah. So let me just, yeah, so I'll have to keep flicking back and forth across screens to do this. But essentially, I will be going through this course. As you can see, I don't need to talk about the introduction to it, but we'll talk about, to start with some normal lymph node structure. Then we'll go through the common B-cell lymphomas, the common high-grade lymphomas, the common Hodgkin lymphoma, T-cell lymphomas, and then also there's a section on bone marrow. And I think that going through this is going to take us probably in the region of at least 3 or 4 months, because I do it every second week. And I want to make it in detail. And I'll also be using this resource to go with it, as I show you. So I want to share a new screen. So this is the resource I will be using. This is the Haempath Atlas, which is now on the Leeds virtual website. This was not previously available. It's only become available in the last 6 months or so. And this is an enormous resource. And so I propose going through this resource gradually with you over the next few months. And this will be a really good teaching opportunity, both for yourselves and for me. Because I don't propose that I know everything. So without further ado, what I will, if everyone's happy with that, can any confirmation that people are happy with that? I will go through it. And these are also recorded and will also be released to everyone. So I'm going to start off at the beginning. So most lymph nodes that we see are in fact non-neoplastic. And of course we focus on neoplastic things, but it's important to see some of the neoplastic diseases. And of course in the British Lymphoma Pathology EQA that we have gone through in the last few months, there have been reactive cases in that. And I think the difficulty of distinguishing reactive from neoplastic lymphomas is very well recognized in the UK. That's why all lymphomas have to be diagnosed in specialist centres, because otherwise there is an error rate of 15%, which is 1 in 8 patients is getting the wrong diagnosis. It's also been recognized by the WHO. So the WHO actually, it's the WHO classification of hematological malignancies, but it does include a chapter on reactive conditions that mimic hematological conditions, hematological malignancies. So without further ado, I will go to, I will just start a new share, go back to this. And I'm going to, so I'm just seeing how it projects. Yeah. So if anyone could just say whether this is projecting at the right magnification, I'm going to go through my simple approach to lymph nodes. And that's the start of this long tour into Haempath. Yep. Okay. Thank you, Sarah. So, an approach to lymph nodes. Now, I think it's always important to keep everything nice and simple, because most things are simple. And if you start from simple things, you will probably achieve at least 95% of diagnosis, and then the other ones you can spend a bit more time on. So I have to keep flicking between the screens to see where I am. So right, so if anyone wants to put anything in the chat or raise their hand to speak, Ava can unmute you, then please feel free to do that. Otherwise, it's a bit difficult talking into a vacuum. So if there's any feedback from anyone, I'd be really grateful for that. A bit like people on the radio asking you to phone in or WhatsApp in or something. So it's really good for me to have that feedback. It is important so it's difficult, this. So one approach to this is that none of this matters, because all that matters is what it looks like down the microscope. And to a degree, for lymphomas in particular, that is true. It is not true for trephines, where the clinical features are of critical importance. Generally, for lymphomas, a particular appearance will match a particular diagnosis. But I think that to guide you into different areas, it is still important to consider the background features. The age and the sex of the patient are important. So Hodgkin's disease, for instance, is unlikely in someone under the age of 15, for instance, where it's much more likely to be infectious mononucleosis. Again, high-grade lymphomas are not common in young people. There are some conditions that can mimic high-grade lymphomas, particularly Kikuchi's, which we may see today. And so it's important to consider the age and sex range to see whether it's appropriate. The presentation is important. They present with weight loss, with stridor, with B symptoms. People with B symptoms need to be taken more seriously. So if you've got a small biopsy and you're a little bit uncertain of it, but there is significant weight loss and there are also B symptoms as well, it may sway your confidence in a diagnosis of lymphoma. It's always important to put everything in the full clinical context. So has the patient got any, what's the full blood count? So you should look at the full blood count in all cases. So are they anemic? Have they got circulating lymphoid cells? Is there any bone marrow involvement? What is the LDH? So where you're querying a high-grade lymphoma versus a reactive condition, maybe in some instances, and there's a high LDH, then again, that would swing you towards a high-grade lymphoma. Size of the node is important. So a normal lymph node will be up to about 1 centimeter. High-grade lymph nodes and Hodgkin nodes can be much larger than that, 4 or 6 centimeters sometimes in diameter. You might get lymph nodes that are 1.2 millimeters on a CT scan, or when you see it in the lab, those could still be a low-grade lymphoma. Sarcoidosis and toxoplasmosis can also result in enlarged nodes. It's probably not so important for diagnosis, but it's important to have an idea what the staging is. So is it a single site or a multiple site? Now that does bear relevance to some of the reactive conditions. So if you've got something which looks quite nasty, if you have Kikuchi's, for instance, with large numbers of T immunoblasts and necrosis, it might look worrying for a high-grade lymphoma, but it's only at a single site in the neck usually, and not associated with any systemic symptoms, not associated with any change in the full blood count, not associated with a high LDH. And so again, the fact that you've just got a single node, because high-grade lymphomas usually present with at least multiple nodes in one area, if not multiple nodes above and below the diaphragm. That also gives you another clue as to whether it's reactive or neoplastic. And there's becoming a real problem in the UK, in the United Kingdom, because we have a service where all suspected hematological malignancies, which include lymphomas, are referred to specialist centres. And the percentage of the cases that are sent to those specialist centres, probably about 25% of them are reactive. So that's, a quarter of the workload is things which, if people have maybe looked a bit more carefully and had a bit more confidence, they didn't need to be sent in as well. That delays diagnosis for the person who's got a reactive lymph node and kind of with the attendant worry that they've got to live with till they get the diagnosis, and it also kind of like overburdens the specialist centres with reactive cases. So, morphology. Always look at low power. So you can look at the lymph node, the whole lymph node, by putting the lymph node on the condenser underneath the stage, and then looking at it at either 2 times or 4 times objective. I don't know if anyone here has done that, but it can mean that you can look at the entire node. Obviously, you can look at the entire node with a 2 times lens, but many microscopes don't have a 2 times lens because it's the most expensive lens, in fact. But you can put the slide on the condenser at the bottom. It's a little bit out of focus, but certainly using a 4 times objective, and ideally a 2 times if it's there, you can look at the entire node and get the entire idea of the architecture. The architecture of a lymph node is really important. It's much more difficult to make a diagnosis without seeing the full architecture. Increasingly in our country, and I don't know about your countries, but we're doing a lot more needle core biopsies, and so they are. It's harder to understand the architecture. As a consequence, we do a lot of CD21 staining, which highlights the architecture and the follicular dendritic cells. But I think that if you're getting whole nodes, you can certainly assess the architecture by looking at the whole thing on the condenser. Look to see if the capsule is intact. If there's any proliferation of lymphoid cells, small cells in particular, do they spread beyond the capsule? It's relatively rare for a lymphoid infiltrate in a reactive node to spread outside the capsule. Look carefully within the subcapsular sinuses. Are there any metastases there? Is there any Kaposi's sarcoma? You can get some pigment in that area, like T2 lymphadenopathy or dermatopathic lymphadenopathy. Is there any histiocytic proliferation? And also you can get a proliferation of monocytoid B cells in the capsular sinuses. It's only when you look at that you decide, are the follicles or are the nodules? So I quite often use the term nodules and follicles to start with in the first assessment interchangeably. So basically, is it diffuse and the same in all directions, or has it got a nodular stroke follicular appearance? If it has got a nodular stroke follicular appearance, then you can look at them, look at whatever these things are, and decide, are these follicles or are they nodules? If they're nodules, you may be thinking about nodular lymphocyte predominant Hodgkin's, nodular sclerosing Hodgkin's. If it's got a vague nodularity and some follicles as well, you might be thinking about a marginal zone lymphoma, because that can give a vague nodularity. You can also get a vague nodularity due to the presence of proliferation centers in small lymphocytic lymphoma stroke chronic lymphocytic leukemia. But if they're proper follicles, then you have to work out whether it's a simple thing, whether the follicles are either reactive or neoplastic. And if they're neoplastic, it's follicular lymphoma. And if they're reactive, it could be one of many reactive conditions. Look at the T cell area. Is the T cell area expanded by some abnormal cells? Is there any suspicion of a T cell lymphoma? Any granulomas? If they're granulomas, are they caseating granulomas? Are they confluent? Are they very well defined? Sarcoidosis, you get very well defined non-caseating granulomas. Everyone talks about asteroid bodies in sarcoidosis. To be honest, I don't see those very commonly. And generally, I make the diagnosis of sarcoid by finding a tight non-caseating granuloma, which doesn't have a kind of cuff of lymphoid cells. Any fibrosis, so that would indicate possibly nodular sclerosing Hodgkin's, and you can get a little bit of fibrous tissue in nodular lymphocyte predominant sometimes, but they're small little fibers. And then in terms of reactive conditions, there are some special conditions, of which I think the most important are cat scratch, HIV lymphadenopathy, Kikuchi's disease, and toxoplasmosis. I don't want to spend too long on this because I want to get onto some slides, and I'm sure you do too. So once you've looked at the low power, these are the high power things to look at. In the follicles, assess the mantle zones. Are the mantle zones well developed, or are they a bit thin in places? The germinal centers, are they lighter or darker at one side than the other? So there's polarity to them. Are the tingible body macrophages? If they're present, then it is reactive. It's very rare to get tingible body macrophages in follicular lymphoma. You may, in a lymph node with follicular lymphoma, get tingible body macrophages in 1 or 2 of the follicles, but even that would be rare. And I've only seen it once or twice. Do the follicles vary in size and shape? In a reactive one, they will generally be variable. If there's a nodular effacement, you can get nodules. So follicular lymphoma, if the follicles are really not very well defined, it can look slightly nodular rather than follicular. Obviously, nodular effacement you mainly see in Hodgkin lymphoma, so particularly nodular sclerosing and nodular lymphocyte predominant. And then you can also get a nodular type effacement with chronic lymphocytic lymphoma. In terms of the low-grade lymphomas, chronic lymphocytic lymphoma, a marginal zone can give a nodular appearance. Mantle cell lymphoma generally doesn't. That's generally very, very monomorphic. All the cells are the same. So if it's a diffuse effacement, again, you just got to decide whether it's small cells or large cells. If they're small cells, could be chronic lymphocytic leukemia without much in the way of proliferation centers. Some marginal zone lymphomas haven't got well developed pseudofollicles and so on in them, so they will be more diffuse. Lymphoplasmacytic lymphoma can be very diffuse, and mantle cell looks very diffuse. And then if it's a large cell effacement, the most common types that you will see are diffuse large B-cell lymphoma and its variants, Hodgkin lymphoma, possibly a T-cell lymphoma. That doesn't tend to, there's, particularly with anaplastic large cell lymphoma, there's usually some degree of organoid kind of pattern with it. It's not completely diffuse. Blastoid mantle has always got to be considered, and lymphoblastic lymphoma should always be considered. And then occasionally you may see metastatic disease in a hemopath practice, but generally it's been weeded out before it gets to you. This is a large immunohistochemical panel, and probably too large for many of the territories that you work in. But to go through it, it's important to have obviously at least one B cell and one T cell marker. Probably the best B cell marker is PAX5. But there are some cells which are negative for CD20, particularly some of the immature lymphoblastic lymphomas, and also obviously patients who are treated with rituximab, which I believe are used in some of your territories. They will be CD20 negative after treatment. So to assess response, you need to be using either PAX5 or CD79A. I guess CD79A will also cover plasma cells, so it's useful for that. In terms of the T cell marker, obviously CD3 is the best. The problem with the T cell markers is that the T cell lymphomas are usually variably positive for one or other of the T cell antigens. So to be certain that you've excluded a T cell lineage, you've really got to do all of the T cell antigens. So you would have to do CD2, 3, 4, 5, 7, and 8, which is a bit of a long list. Because whereas the B cell lymphomas are all positive for 20 and 79A, the T cell lymphomas, as I'm sure you're all aware, are very variable. CD3 will cover most of them, but if CD3 is negative, it doesn't exclude a T cell lymphoma. In terms of the other markers here, I would say CD10 and BCL2 are particularly useful. CD10 for germinal center phenotype, and BCL2 to identify, to distinguish reactive versus neoplastic follicles. Ki67 is a valuable marker, particularly in the high-grade lymphomas, and to distinguish a Burkitt from a high-grade B-cell lymphoma. TDT is really critical because it's the only way to differentiate the high-grade lymphomas from lymphoblastic lymphoma, which does have a different treatment need. Cyclin D1 is highly specific for mantle, so I would include that one in. Obviously, CD30 and CD15 are valuable for Hodgkin lymphoma and should always got to be used together. And some of those other markers, OCT2, BOB1, they're not particularly of diagnostic value. They don't distinguish things too much. EBV, well, there's only a few lymphomas like the natural killer cell lymphomas in the nose. These are EBV positive, but a lot of the others, they can be EBV positive or negative. So again, it doesn't help. Annexin A1 and DBA44, they're really for diagnosis of hairy cell leukemia versus anything else. So it's not really a lymphoma thing. And you can diagnose hairy cell leukemia, I think, quite confidently with a combination of a B-cell marker and a very good reticulin stain, actually, because kind of reticulin stain that goes around all the different little cells and your CD20 positivity. There isn't really anything else that shows that. Got a number of ones at the end there, ICOS and CXCL13. These are for the T follicular helper cell lymphomas like angioimmunoblastic and so on. But again, they can be diagnosed quite confidently with good morphology, and particularly with a PAS stain, actually, which is really good for highlighting the vasculature in lymph nodes. These are the panels that I would use. You can see it's quite long, but a reactive lymphoma, obviously you've got two B-cell lymphomas. Two B-cell IHCs, CD3 for T cells. 21 is, if you're going to have 21, and you need 21 and 23. CD10, BCL6, maybe not necessary. Ki67, probably not necessary. PAX5 is becoming more and more a useful marker, I think. For low grades, you have to distinguish follicular, mantle, CLL, lymphoplasmacytic. So CD20, 79A, 3, CD5 for mantle, and CLL, cyclin D1. CD23, particularly in marrows, might often be negative in CLL. Sometimes we use LEF1 and, SOX11 and LEF1 to distinguish mantle cell versus CLL. But I think, in fact, generally you can do the job with good morphology. Mantle cell doesn't have big cells in it. They're all small. CLL will have some big cells in it. High-grade lymphoma is really where you've got to have quite a wide panel, because you need to have markers to distinguish high-grade lymphoma from Burkitt's possibly, and also a TDT to exclude the possibility of a lymphoblastic lymphoma. Hodgkin's, I think a really good marker in Hodgkin's actually is in fact PAX5, because nodular lymphocyte predominant Hodgkin's, the large cells will be positive for PAX5 because it's essentially showing B-cell antigens. And if it's nodular sclerosing, you'll get weak PAX5 in the Hodgkin cells and strong PAX5 in the kind of control B cells within the section. So PAX5 is actually quite a good marker for Hodgkin lymphoma. It's probably more specific than a lot of those other ones. Obviously CD30 and 15, but 30 can be positive in lots of other things, and 15, some Hodgkin lymphomas are negative. But if you've got something which looks like Hodgkin's and the large cells are positive for 30, negative for 15, and they're weakly positive for PAX5 compared to the infiltrating B cells, then you can confidently make a diagnosis of lymphoma. So the T-cell lymphoma has basically got a large T-cell panel there to cover all the T-cell antigens, plus CD30 for anaplastic, ALK for anaplastic lymphoma, ALK positive or negative, and then the last set at the end, CXCL13, ICOS, CD10 and BCL6. They are the T follicular helper cell markers. I've not put in there actually CD56 and EBV, which you could be using, which you could use for, and lysozyme, which you could use for the natural killer lymphomas. And myeloma is a separate talk, which I've given separately, and I'll do separately. Okay, so that's a run through. So now we'll probably, is everyone okay with that? Have I still got an audience? Just checking, please. Yep, great. Thanks, Sarah. Okay, so now we will move on to the... And can you still see me? I don't know, because I can't see myself now. Yeah. When I go to... When I share, can you see me or do I disappear? Because I don't know myself. Anyone able to tell me? Do I still appear or not? Out of interest, maybe you disappear. Okay, so yeah, so is that okay for people? They don't mind, I guess, as long as they can see the slides. That's all that matters. Right, no worries. Excellent. Right, we will proceed. So now what we're going to do is, you know, as always, you know, start to walk before you can run. So we're going to start off. I should be sharing this now. Yep. And I don't know. So if there's anything in the chat that comes through, Ava, if you're able to alert me, because when I am talking through the slides, I can't see the chat button because of the different tabs. Would that be okay if someone just alerts me? Yeah. Okay. Right. So we're going to start off at the start. This is what we're going to cover over the next few months: reactive lymphomas, high-grade lymphomas. I'll probably actually switch the order around and start with reactive, and then the low-grade, then the follicular, and then the high-grade, then the Hodgkin's, and so on. So we'll start off with the reactive. Now, some of this is going to be simple, so bear with me, but we will build it up. And I'm very happy to have questions and comments. So we'll start off with follicular hyperplasia. Now, I'm sure that you can all recognize follicular hyperplasia. This is actually a 5-year-old male. It's a tonsil. So interestingly, I'm sure a lot of you see more pediatric cases than I do, because we separate adult and pediatric pathology in our country. And you can get very, very florid proliferations in children, actually. But it's important to consider reactive and how you distinguish reactive from neoplastic, because, you know, the most important thing is, can you distinguish the two? So if you can confidently identify reactive nodes, you can confidently at least say something is lymphoma. So this is reactive tonsil, actually. And we can look at the germinal centers. You can see that there is a variety of size and shape of the follicles. It's obviously follicular, looking at it at low power. So you've got follicular structure, low power. This is clearly not lymphoma so far, but we need to look at these in more detail. Do these look reactive? So I think even at this power, we can see many features that mean these are reactive. And we're seeing these features not just in one follicle, but in many follicles. That reinforces our confidence. So you can see here, can people see the cursor? Okay, right. Right. So let's just see what happens here. Right, can people see the... Can people see it now? Yeah, right. So what I've worked out with this, I have to check, I have to move tab across all the time. What I could do instead is try sharing my entire screen, which might be more efficient. Just bear with me one moment, please. So if I share the entire screen, so can you see my entire screen now? Can you see my entire screen now? If I go to this, can someone see the follicular lymphoma? Yes. And now has the lymphoma gone? And you've got tons and tons of images. Can someone tell me if I've moved to another screen? Yes. Okay. Right. So there's the follicular lymphoma. So hopefully you should see me zooming in and out on this follicular lymphoma now. Is that correct, Ava? Because I can't see. Yeah. Okay. So here we have a good example of a reactive lymph node, and what we're looking for here is follicles at low power, and then as you go in, you have the nodules, stroke follicles. They look like follicles as you get closer to them, not just nodules. And you can see the features that I said that need to be present in reactive follicles, and these should be present in at least some, if not most, or all. Probably won't be present in all because of cross-cutting. This is a good example. You've got a different color there versus there, the same different there versus there, there versus there, there versus there, and that's because you've got different cells in this part. These are more centrocytes, and you've got larger cells in this part. So you've got polarization across the follicle. You've also got a mantle zone around the follicle, which is relatively well developed, and where the germinal center has polarization of a kind of like dark area and light area, the mantle zone also shows polarization in that it's thicker on one side than the other. And that's the same with most of these nodes you look around. That one is thicker there than there. That one is thicker there than there. That one is not quite certain. So you've got to look around, take a sample set really. That one is thicker there than here. If you look into it, that's definitely thicker there. This mantle zone here of small cells thicker than there, and so on. And that's the same in most of these follicles. The other thing is that even, maybe not at this power, but certainly at this power, you can tell that this is reactive because there's lots of little holes everywhere. Maybe not so much in these, but up here, they've got tons of little holes everywhere because these are the tingible body macrophages here. Check everyone can still see it. Yep. These are the tingible body macrophages, which are present because of BCL2 switched off, so you get apoptosis of self-reactive cells, and you can see these even at low power. So at low power, you can say, yep, that's reactive, and just focus in. Have we got lots of tingible body macrophages? So hopefully no one would have a problem with that. But in some cases, the follicles aren't that many. There's in a tonsil where you've got tons of them, and it can be harder to see. But look at those key features. So polarity across the germinal center, polarization of the mantle zone, and also, most importantly, tingible body macrophages. Now, I have seen reports that you can get tingible body macrophages in follicular lymphoma, but it's very rare. And you would only see it maybe in 1 or 2 of the follicles within the follicular lymphoma. So you see something like this, it's definitely reactive. In terms of the immunos, obviously it's positive, the follicles are positive for CD20. CD3 highlights the interfollicular areas, but you've also got follicular T follicular helper cells, and this is where angioimmunoblastic lymphoma derives from, these cells within the follicle. And you can see also that shows the T cell shows nice polarization as well. So you've got, in the light area, which is down here, you've got high numbers of the T follicular helper cells and low numbers up in the dark area. Most important 2 stains are, apart from CD20, are CD10 and BCL2. So CD10 highlights the follicular, the germinal center cells, and in contrast to, apart from a tiny bit there, but in contrast to follicular lymphoma, CD10 is all concentrated in the germinal centers, whereas in follicular lymphoma, CD10 is positive in the germinal centers, but you also get cells spreading out into this area. Let me just see if I can find an example of that. Jumping around a little bit. Maybe not the best example. This is CD10 here, but the CD10 hasn't spread out. Yeah, you can see it here. So we've got CD10 within the follicles, but we also got CD10 positive cells out in the interfollicular area in follicular lymphoma. So let's just go back to where we were. You can see potentially this could take us forever. Okay, BCL2 is obviously strongly negative within the germinal centers, and using BCL2 to distinguish reactive and reactive versus neoplastic lymph nodes is really only useful in the context of reactive follicular hyperplasia versus follicular lymphoma. In the other subtypes of lymphoma, BCL2, because BCL2 is positive in follicular lymphoma, but identifying BCL2 is not as helpful. But if you have a combination of positivity for CD10 and positivity for CD20 in the same areas, and negativity for BCL2, then that is follicular hyperplasia. And if you get positivity for BCL2, then that's follicular lymphoma. BCL6 also is another germinal center marker, but it's probably not as important to CD10 in this context. I think for diagnosis of Burkitt lymphoma, it becomes more important in particular. CD68 highlights some histiocytes, both within the interfollicular areas, and also these are the tingible body macrophages that we saw. These are the cells which are forming the little holes on the H&E, mopping up the kind of like dead apoptotic autoreactive cells within the germinal centers. CD30, so occasional CD30 positive cells. So it's very important never to interpret CD30 without a context. If you look at CD30 and use it for diagnosing Hodgkin's, you will find CD30 all over the place. Reactive lymph nodes, infectious mononucleosis, other types of lymphoma. CD30 has always got to be looked at in the context of what's the size of the cell it's staining, whereabouts of the cell is it staining. So if you look at this case here, you've got a population of CD30 positive cells there, right, in an interfollicular area. And then you've got follicular hyperplasia outside it. So you've clearly got reactive activated cells, which are therefore CD30 positive in the interfollicular areas. I had a case several years ago of sarcoidosis, and it was a strong, confident diagnosis of sarcoidosis. There was high angiotensin converting enzyme. The radiology was consistent with sarcoidosis. The lymph node looked like sarcoidosis, and it was reviewed. The patient went on to develop Hodgkin lymphoma a few years later, maybe 5 years later. At the time when they diagnosed the Hodgkin lymphoma, they looked at the previous biopsy, which I had reported as sarcoidosis, and they got the biopsy and they got the block and they cut more sections from the block, and they found an area of interfollicular Hodgkin's, which they said that I'd missed. Well, I hadn't missed because it was one follicle in a subsequent section, and the clear diagnosis was of Hodgkin, of sarcoidosis. I was a bit worried about that. So then what I did is every case of sarcoidosis possible that I saw thereafter for the next 6 months, it turned out to be quite a lot of them actually, I did CD30 and CD15 on all cases. And in every case, I saw little groups of Hodgkin cells like this. So in fact, I think the patient never had Hodgkin's. I think they were just these interfollicular groups of CD30 positive cells. Yeah. So always interpret CD30 in the context of everything else and in the context of multiple stains. Ki67. So Ki67 is actually quite high and also shows polarization. It's higher in the dark area, lower in the lighter area. This is the proliferative area. Interesting that the T follicular helper cells are more present in the lower proliferative area than the higher proliferative area. And then you've got IgD, which stains the mantle zones nicely. Okay, so that is a good going example of a reactive follicle. I think we've got a tonsil, which shows much the same features. Actually, I don't think we need to go through that one. So having looked at that, we can look at some of the other reactive conditions which are non-neoplastic but can cause confusion. Right, I'll start with this one. So this is a lymph node from a 60-year-old male with rheumatoid arthritis, and they can get lymphadenopathy. So it was a needle core biopsy, which does make it harder to interpret. Let's just see if we've got a CD21. No, they're not giving us a CD21. They've given us a CD10 though, and they've given us a BCL2, and they've given us a CD20. So on the basis of the 10, the 20, and the BCL2, we can say there's reactive. So let's start looking at the H&E to start with. I'll just close down some of these other tabs because I've got tons of them open. Just before I go any further, is this working for people or not? This new style that I'm trying today. This is the first time I've done it like this. Anyone prepared to say that it's either working or not working? If it's not working, I'll change it. But if it is working, if people are happy with this approach, then I'll continue. Okay, thanks, Edgar. That's great. So here we have a needle core. I'm not sure if it is a needle core, actually, a bit of a scrappy biopsy, but it looks a bit like a needle core. Now let's look into it. So looking down this core, a bit difficult to see what's going on in this core. Certainly architecture has been disrupted a bit in this core. In this core, we do have 1, 2, 3, 4, I think, reactive follicles, maybe another one there, another one there, and then the rest of it, another one there. And then here, you've got 1, 2, 3, 4, and a vaguely dispersed area here. So let's look at these follicles here. So we'll look at one of the follicles. This is clearly reactive. We've got all the features we need. We've got polarization, a lighter area, a darker area. We've got a mantle zone, which is polarized. It's thicker there, it's thinner here. We've got tingible body macrophages, nicely shown up here. You can see them even at low power. And again, there's another follicle here, again, a thicker mantle zone. Polarization of the germinal center not quite as apparent in this one, but a thick mantle zone. This one here, again, polarization. And the immunos, if we look at the immunos, so CD20, we'll highlight the B cells. And there they are, lots of B cells, B cell follicle areas. And these areas should be CD10 positive and BCL2 negative. So let's look at the CD10 first. Where's the 10? There's the 10. So the 10, that's the control down there. The 10 is highlighting the germinal centers nicely. And there isn't any 10 outside, apart from 1 or 2 occasional cells, which I think we can live with. And then the BCL2 is negative. So the combination of positive CD20, positive CD10, and negativity of BCL2 indicates that this is reactive. What else is going on in this node? So if we go back to the H&E, which I think is here, we've got these expanded areas in between, and in these areas we've got lots of plasma cells here, more plasma cells here. So lots and lots of plasma cells, also quite a lot of eosinophils as well, actually. So there's eosinophilia and lots of plasma cells. Again, lots of plasma cells here, here, here. And in fact, that's highlighted on the CD138. We've got tons of plasma cells. If you see 138 like this, always be cautious that 138 can also stain epithelial cells. I don't think it's relevant in this instance, but always think, could these be epithelial cells? I think the pattern here does look a bit like epithelial cells, but we know from the H&E they're not epithelial cells, they're plasma cells. So I think we can go with that. So the combination of follicular hyperplasia and a plasma cell increase, you can get that in Castleman disease, but you can also get it in rheumatoid arthritis. Of course, the follicles in Castleman's disease don't look the same as in a reactive follicular hyperplasia. The Ki67 again is high within the germinal centers and does show a degree of polarization dependent on cross-cutting. So for some of them must be quite small and they've just cut across tangentially across the more proliferative areas, but in others you have got still some polarization, which and the Ki67 is low in a neoplastic follicle. Because follicular lymphoma is driven by failure of apoptosis rather than increased proliferation. So it's a nice example of rheumatoid arthritis, lymphadenopathy with increased plasma cells. So let me just see. I've got another computer on the go, which has logged itself out, so I just need to reopen it. So in rheumatoid arthritis, you get some follicular hyperplasia, and you've often got interfollicular plasma cells. And it may sometimes, therefore, resemble the plasma cell variant of Castleman's disease, but in that, you really get massive increases in the plasma cells. Okay, it's coming up towards the hour. What I'd like to do now is see if I can, if I just get some feedback. So I'll just stop the share. Yeah. If I get some feedback from people as to how that session is working, and then I can tailor it more for the next one. And the next one, I'm going to go through more reactive conditions, and then the following session that I do, which will be in not 2 weeks, but beyond that, I'll start going through the B-cell lymphomas. Is that format helpful for people or not? Okay, so Sarah says it works well doing the cases and going through the stains, but comparing the IC to the differential. Okay, so I don't know, Ava, if you're able to unmute Sarah, and I don't know, Sarah, if you can talk and expand on that point, because that's a really good point. I just want to understand exactly what you mean by that, so I can tailor it in future.
I don't think I can unmute, but she should be able to chat.
Okay. So Sarah, do you? Okay. She's in MRI. Okay. Yeah. I'll see you there. So what I will do is I'll kind of like use the use that format, and I'll go through the reactives, the low grades, the high grades. But as I've just done, I'll switch back and forth between the differential immuno use and features between different conditions as I did for reactive follicular hyperplasia versus follicular lymphoma. And I think as we go on, I will get slicker at it. Are there any comments from anyone else? And just as a matter of interest, can I see where people are in the world, please? That's very encouraging for us all. I know Edgar is in Zambia. Sarah, I don't know where Julia is, for instance. People are able to write in the chat which countries they're in. Kenya, thank you, Julia. Okay, and Mary, where are you from, Mary? Where are you joining from? India, great, okay. So this project started in Zambia and wow, Bosnia, okay. So this program started in Zambia and Kenya in 2000 and I think 22. Can't remember, 21 or 22. So it's been going some time now. I think it was actually in 22. So I'm glad people are joining still from those territories. Thank you. Okay, so next week it'll be Dr. Nick Orsi, who I can't remember where he's actually based. Let me just. Very rude of me, I know. I think he's at UCL. No, he's actually at Leeds. So Nick Orsi is a pathologist in Leeds and specialist gynae pathologist. So he'll be talking on endometrial pathology next week. And he's an excellent speaker. So please share the link will come out on WhatsApp and through the normal email routes. Ava will put it out in advance. It'll be the same time in your territory, wherever you happen to be. And I look forward to introducing Nick to a large cohort of you all next week. And I'll probably have to go back to the PM room now. There's no rest for the wicked. And Ava, if you let me know how many people attended as usual, thank you. And thank you very much for your continued support of the program and for Diagnexia's support of the program. And thank you all, everyone where you are, for your attention. And I hope you have a good morning, afternoon, evening, and night, wherever you happen to be. Thank you very much.